Hello everyone, myself SP Tiwari, final year MBA student at GMC Azamgarh. So today we are going to deal with acute appendicitis. हम लोग इस वीडियो में बेली के जो समरी बॉक्स हैं उसको मर्ज करेंगे प्लस ऑल अदर कंटेंट जो कॉमनली हमारे सिलेबस का पार्ट है. तो to begin with, we'll start with the position of or rather location of appendix. So as you can see, the most common location is retrocecal, which is about 74%, right? 74%. The second most common position is pelvic, that is 21%. Then thereafter it comes paracecal, which is about 2%. Then perileal 1%, subcacal 1.5%, and post-ileal 0.5. So the least is post-ileal and the maximum is retrocecal. Very often question is been asked from this category that the position of the appendix. So now let's deal with the risk factor of perforation of appendix. So the perforation is a different thing, but since it is given in belief, we'll deal with it. Perforation of appendix is common in extremes of ages, either the younger or the elderly, immunosuppressions, diabetes mellitus, fecolith obstruction, pelvic appendix, and previous abdominal surgery, which could lead to the weakness of the muscle. Right now, let's begin with the acute appendicitis. So, acute appendicitis is an acute inflammation of appendix, as the word citis is defining itself. Pathophysiology is like aerobic and anaerobic. The aerobic part is caused by E. coli, and the anaerobic is caused by bacteroids. Pathophysiology can be divided into two parts, obstructive and non-obstructive, right? Obstructive and non-obstructive. The obstructive part, the cause could be fecolith, the most common. Be aware, most common is fecolith. Parasite like vermicularis, carcinoid tumors, which we'll deal later, carcinoma of cecum, and Crohn's disease. These are few obstructive causes of rather pathophysiology. Then comes with the clinical feature. Clinical feature of acute appendicitis could be pain in right iliac fossa. Right iliac fossa. There could be fever, anorexia, nausea, and vomiting. The very common symptoms. Appendix is pelvic in position, then it could cause diarrhea. Why it would cause diarrhea? So it would irritate the rectum and the bladder also. Most more commonly, the pelvic position, it will irritate the rectum. On examination, like let's deal with the table here given in belly. Okay, symptoms of appendicitis. Yeah, what is this? Periumbilical colic, pain shifting to the right iliac fossa, right? Anorexia and nausea that we have already dealt with. On examination, we'll get right iliac fossa tenderness, right iliac fossa rebound tenderness, guarding of the muscles present, and increased heart rate, that means tachycardia. Okay, so starting with the initial, we dealt with the position, the risk factor of the perforation of appendix, the acute appendicitis pathophysiology, which could be obstructive and non-obstructive, clinical features with included pain, fever, nausea, and periumbilical colic. On examination, right iliac fossa tenderness, the rebound tenderness, guarding, and the tachycardia. Signs to be elicited in appendicitis are pointing sign, Rowinsing sign, Swas sign, and obturator sign. What are all these? Let's deal with it. So, the Rowinsing sign is press on the left iliac fossa causes increase in pain in right iliac fossa. Okay, so let me show this. Yeah, so the press in left iliac fossa will cause the rise of pain in right iliac fossa. Are you getting this? This is right iliac fossa. This is left iliac fossa. Fine. Rousing sign is pressing on left iliac fossa, causing increasing pain in right iliac fossa. The second sign to be elicited is SWOS sign. Positive retrocecal in position, pain on hyperextension of the hip. The hyperextension of the hip will cause the pain as retrocecal basically lie on the psoas muscle. Next is obturator sign, which is positive in pelvic in position. The pelvic position is about 21%, as we have dealt already. Here it is pelvic 21%, and the retrocecal is 74%. So here what you are learning is the SWOS sign is most common in retrocecal position, which causes pain on hyperextension of the hip, and the obturator sign, which is positive in pelvic in position, pain increases in right iliac fossa on internal rotation of the hip. So there are two different things: hyperextension of the hip and the internal rotation of the hip. Okay, internal rotation of the hip is related to the obturator sign, which is related to the pelvic position of the appendix, and the former one is like hyperextension of the hip is related to the SWOS sign, which is retrocolic position of the appendix. Fine. The next is pointing sign. Patient uses index finger to localize the maximum site of tenderness. The patient himself will show where the pain is rising or the tenderness is showing, which is the most common like McBurney point. Okay, here it is. This is the umbilicus part, and it is the ASIS. From ASIS, the lateral one third, and medial 2/3. The point which is it's known as McBurney point. Very important. At McBurney point, base of the appendix is found. Site of maximum tenderness. टीनिया कोलाई का बेस तीनों टीनिया कोलाई मर्ज करते हैं उसमें, ठीक है, वहाँ बेस पाया जाता है. नेक्स्ट इज Bested sign, that is on distal rectal examination, pain increases in right iliac fossa. This is not more common, but this four, which is given in belly itself, the pointing sign, the rousing sign, the SWOS sign, and the obturator sign are must to be remembered. Fine, let's deal with the investigation part. Investigation part includes CBC, the very often the first one to be done, ultrasound on of the abdomen and pelvis, contrast enhanced CT scan of abdomen. Now, one more summary to be read. Clinical signs in appendicitis, that is pyrexia, fever, localized tenderness in right iliac fossa, muscle guarding, and rebound tenderness, what we have already done here, right? Rebound tenderness, guarding, and tachycardia. The fever was also there in the clinical feature part. Now, one important score to be measured in the case of appendicitis is that Alvarado score, that is Mantrel score. Here it is included into three parts like symptoms, signs, and laboratory. Symptoms include three basic things: migratory right iliac fossa pain, anorexia, nausea, and vomiting. Nausea and vomiting. Now, migratory right iliac fossa pain, all the scores are between 1 and 2. That means either 1 or 2. Okay. So, migratory right iliac fossa pain would score 1, anorexia will score 1, nausea and vomiting would score 1. Fine. This three includes other part of symptoms. Fine. The next three are the part of signs, which will include tenderness in right iliac fossa, which would score 2. The very important point to be remembered. Okay. Rebound tenderness would score 1. Elevated temperature would score 1. So the first thing we have got that is dealing with the score of 2 is tenderness in right iliac fossa. The next part is laboratory part. Leukocytosis, which will score 2. Shift to left, which score 1. So the two things which we got scoring 2 is leukocytosis and the tenderness in right iliac fossa. Fine. So this concludes the total score to be 10. Total score to be 10. Now what will come to a conclusion with? We'll come to a conclusion that confirmed acute appendicitis would be said only if the score is equal to or greater than 9. Okay. High likely The score, high likely appendicitis would be like the score would be greater than or equal to 7 to 8, and contrast enhanced CT abdomen when score is less than 6, means when you have to go for a uh, to confirm your diagnosis. Now, differential diagnosis for acute appendicitis. Better than this, the written part will directly jump onto the Bailey's table. Okay, so here we go. Differential diagnosis for acute appendicitis for children, adult, adult female, and elderly. For children, the most common is gastroenteritis. No, sorry, mesenteric adenitis. The other one is gastroenteritis, Meckel's diverticulitis, intussusception, Henoch's colon purpura, lobar pneumonia. Regional for adults, it includes regional enteritis, uteric colic, perforated peptic ulcer, torsion of testis, pancreatitis, rectus sheath hematoma. For adult female, it includes Michel MERS, PID, pelvic inflammatory disease, polynephritis, ectopic pregnancy, torsion rupture of ovarian cyst, endometriosis. The elderly would include diverticulitis, internal obstruction, colicky carcinoma, torsion, appendix epiloicae, mesenteric infraction, and leaking aortic aneurysm. These are some differential diagnoses to be dealt with. Let's come to the management part. Management part of acute appendicitis include surgical approach, appendectomy, which could be open or laparoscopy. Now the open has three major incisions to be dealt: grid iron, Rutherford Morrison incision, and lens. The grid iron is muscle splitting in nature. Be specific to the word muscle splitting in nature. Okay. Rutherford would be muscle cutting in nature, and lens would be cosmetic. The grease line with on the skin, it won't be visible for the cosmetic purpose. Okay. So let's observe this. The first one to be is lens line. Now, as we know that it is umbilicus, and here it is ASIS, the lateral 1/3 and middle to 2/3 is the McBurney point. Now, the grid iron is the perpendicular line here, which is going perpendicular line on the McBurney point. Fine. The second is Rutherford. Rutherford is a little above the mid McBurney point, and the lens line is here. Okay. uh, Above the McBurney 2 centimeter about here it is written. Yeah. Transverse or skin erase. Sorry. Yeah. Transverse or skin crease, lens incision for appendicitis 2 centimeter below the appendicitis, centered or mid-clavicular mid-inguinal line. So mid-clavicular and mid-inguinal center 2 centimeter below the umbilicus. And here is grid iron incision appendix in right angle to the here perpendicular, and the Rutherford model is it incision is shown here. Okay. The next part is, so basically you have to remember the three types of incision: lens, grid iron, and Rutherford. The grid iron would be a muscle splitting, and the Rutherford will be muscle cutting, and the lens would be a cosmetic for cosmetic purpose. For perforated appendix now, could you just remember the risk factor for perforation of appendix? Yeah, we actually started from that. What are risk factors? Extremes of ages, okay, extremes of ages, immunosuppression, diabetes mellitus, we call it obstruction, pelvic appendix, which is about 21%. See, often when you spell the data, you will remember it. Previous abdominal surgery. Okay, now let's come to the main part. Perforated appendix. Signs of symptoms of peritonitis, which is guarding in nature, guarding of muscles, rigidity, and diffuse abdominal pain, which will lead to approach of exploratory laparotomy. एब्सेस होगा तो क्या करेंगे, एब्डोमिनल ड्रेन करेंगे. गैंग्रीन होगा तो हम देखेंगे क्या, बेस और टिप. टिप को हम अपेंडिक्टोमी करेंगे. बेस में क्या होगा, अगर सीकम वॉल प्रेजेंट है तो राइट हेमिकोलेक्टोमी करेंगे. राइट, अगर बेस में सीकम वॉल इफेक्टेड है तो हम क्या करेंगे, वी विल डू राइट हेमिकोलेक्टोमी. If cecum wall is not associated, then we'll go for appendectomy, bury appendicular stump and persisting stooge. So the stump should be approx or above 4 mm in length. The next thing is appendicular mass. Appendicular mass is dealt with the Osher-Sharon regime. That is, mark the appendicular mass. The patient is kept nil per oral, IV fluids, IV analgesic, IV antibiotics. Monitor vitals for 4 to 6 weeks and then come for appendectomy. So we are actually decreasing the mass and then we'll go for appendectomy. So here the last thing, criteria for stopping conservative treatment of an appendix mass. So what are the criteria when we will think that okay, let's stop the conservative treatment and go for the approach for the surgery purpose? The criteria would be a rising pulse rate, the first one, increasing or spreading abdominal pain, the second one, increasing size of the mass, the third one. These 3 points are very important to stop the conservative treatment and think other than that. So the last thing is pre-operative investigation in appendicitis. So pre-operative before surgery, the basic one, routine full body count, urinalysis, and selective could be like if in pregnancy, then appendicitis in pregnancy, then pregnancy test, urea electrolytes, C-reactive protein for inflammations, supine abdominal radiography, ultrasound of abdomen and pelvis as usual to confirm the diagnosis, contrast enhanced CT abdomen or pelvic CT scan, consider low dose protocol in majorly we will conclude by clinical diagnosis, but to support or to confirm our diagnosis we'll go for CT. Hope you loved the video. If so, please do like, share, comment and subscribe the channel. Thank you.